When you come to see us at Ohio Reproductive Medicine for your first appointment, it's a getting to know you session. And a lot of people will come in here and they're just at the beginning of this journey and they haven't done any kind of evaluation and they haven't had any prior treatment. And in that case, it's unlikely, it's possible, but it's unlikely that I would start you into an IVF cycle, an in vitro fertilization cycle, the minute that I meet you. Usually that type of person, there would probably be a set of evaluation tests that would be done. And then depending on the results, we may or may not recommend in vitro right away. But on the other hand, if the question is, how the heck long does it take to start doing IVF with us? If you know that's what you need and you're coming in the door ready to go, it will probably take about 4 to 6 weeks before you would actually be starting the treatment. There's just some preliminary testing and things like that we have to get taken care of before we get started. It's not really too long considering the journey that most of you have already been on, but that's the answer. If you were ready to go, it would still take a little bit of time. What happens with IVF is just big picture. We're going to stimulate a woman's ovaries with fertility drugs. They're given by injections. I can show you. Here we go. This is one of the types. This is not the only one we would use, brand, but basically it's filled with medicine right in here. And there's a window here and you dial the dose. And I hope nobody is going to pass out from seeing a needle, but there's the needle. I don't know if you can see it. Can you guys see it? I hope you can see it. Anyway, it's a little tiny needle. And these are very strong medications. Do you remember maybe years ago, there were TV shows about people who had, 6 kids, 8 kids, all of that. And they didn't do IVF. They used this treatment that makes lots of eggs. We don't do that often anymore, but this medicine, that's this medicine. You take this medicine, you have monitoring visits to check how you're responding to it. And then you come in when you're ready and you have multiple eggs developed. You come into the office here. We give you anesthesia. We remove the eggs through the vagina. It's not an actual surgical procedure. There's no cutting anything. And then after that, you wake up and the rest happens in the lab. And here's a picture. Hope you guys can see it. This is what an egg looks like. And then these are all the stages of embryo development all the way down to that, which is the blastocyst embryo that's ready to implant. So when it's time to get pregnant, we transfer one of those blastocyst embryos and we'll typically freeze the rest of them. So that's just a general idea about what happens during IVF.
One option, once the embryos are created, is the person can have a fresh embryo transfer, which means that about 3 to 5 days after those embryos are created, either one or several embryos are placed into the uterus, and that's called an embryo transfer. The second option is to do something called a freeze-all. And there's several different reasons why we might do a freeze-all. So sometimes if a patient overstimulates, she may have a better chance of getting pregnant if she does a freeze-all and has a future frozen embryo transfer. The second reason why somebody may have a frozen embryo transfer might be if they have a polyp that comes up or a fibroid is noted. There may be something wrong with the endometrium or the lining of the uterus. And then another reason that we often will do a frozen embryo transfer would be if a patient's progesterone hormone level is too high on the day of the trigger shot, because that can be associated with a lower chance of getting pregnant. So if any of those things come up, the patient may create the embryos but freeze them, and we kind of call that a freeze-all, and that might be her cycle. And those embryos might be used the next month, or they could be used at any point in the future. And then the third option does involve a freeze-all cycle, but it may also involve doing preimplantation genetic testing for that patient. And there are 3 different types of preimplantation genetic testing. One that is used, it's called PGT-A, which stands for aneuploidy. And that's when we test the embryos to see if they have the correct number of chromosomes. So that can be things like for a patient who may be over 35 and is worried about a higher risk of things like Down syndrome, that might be the testing that they choose. There's also called PGT-M. That is what we use for patients who they and their partners may carry a hereditary disease. And then there's something called PGT-SR, which is one of the, probably one of the least common types of genetic testing, but it's for patients who have something called a balanced translocation. So those embryos are grown, biopsied, then frozen, then we wait for the results, and then they have a frozen embryo transfer in the future. So, well, it depends on how you want to define it, but one cycle from the time that you start taking the stimulation medications to the retrieval is usually about 2 weeks. It kind of varies from person to person, but roughly it's probably like, I don't know, 10 to 15 days. And then a frozen embryo transfer cycle, again, depending on how it's done, is usually 1 month. So intrauterine insemination, or IUI, is when the sperm is placed into the uterus. So on the day of ovulation, a person would come into the office and this little tiny catheter is used that goes, so the woman comes in, she has a speculum exam, we look at the cervix, and then we use this little tiny like catheter to put sperm up into the uterus. And that sperm has also been prepared. So it's been kind of like filtered, and so it's like, so we can safely put it into the uterus. So an intrauterine insemination means that we're putting the sperm into the uterus. Again, it can be used with partner sperm, donor sperm, directed sperm. So if it's not necessarily your partner, but you want to use someone's sperm that you know, it can be that. So the important distinction with IUI is that everything still happens in the body. Fertilization, embryo growth, everything happens in the body. IVF, those steps happen in the laboratory. So IUI is a great option for many patients. I mean, it's usually the first step of infertility treatment for a lot of patients. It works great. It's pretty low tech. It's relatively low cost compared to everything else. And it works for a lot of people. However, it does, for an IUI to be successful, the sperm have to be good enough and the fallopian tubes have to be good enough too. With IVF, if there's any concern for like either of those issues, the sperm or the tubes, IVF is usually the best option for patients. So there were some very good studies that came out a few years ago, which have kind of dictated the management of patients with infertility. And what I'm specifically talking about is something called unexplained infertility, meaning that if you don't know what's going on with a patient, like fallopian tubes are good, hormonally good, sperm looks good, the first step for those patients should be that they consider doing medicated IUI. Usually by medicated, we mean either having that patient take Clomid or letrozole. And in these studies, they had patients do that 3 times and 100 couples, and they all did a medicated IUI, then about 10 of them would have a baby. Okay, then if you took the remaining 90 and did a whole nother round of treatment, about 10 more. So you took the remaining 80. So that's what we mean by cumulative. And what they found was after about 3 cycles of medicated IUI, the chance of getting pregnant started to go down. And it's not that the procedure was less successful. It's like the people that didn't get pregnant with the first 3 may have an issue going on that isn't getting fixed by the medicated IUI. And so it may be that those people that are left need IVF to help them conceive. So the recommendations have basically said, IVF should be discussed if someone has done 3 medicated IUIs and they haven't conceived. And what they found was after about 3 cycles of medicated IUI, the chance of getting pregnant started to go down. And it's not that the procedure was less successful. It's like the people that were left in the group that didn't get pregnant with the first 3 may have an issue going on that isn't getting fixed by the medicated IUI. And so it may be that those people that are left need IVF to help them conceive. So the recommendations have basically said, IVF should be discussed if someone has done 3 medicated IUIs and they haven't conceived. Like, is IVF right for the patient? The answer may be no, or the answer may be, well, we want to do a couple more, or remember that one IUI, the count wasn't that good. Does that one really count? Maybe we should do another one. But, you know, it's really hard, as you know, to not get pregnant. And so we definitely don't want to just keep doing things that aren't working and having people unnecessarily suffering and paying money and doing all these things that aren't working, when it may be that they really need IVF. So that was a very long answer to the question of probably about 3 to 6. And at about 3, usually we're having conversations with our patient about what their plan is for the coming months.